report about cardiovascular disease. Patient information, patient name is Trần Thị C. She is a female patient. Date of birth in 1946. Right now is 71 years old. Address in Kiên Giang. Her occupation is a farmer, but she retired now. She is hospitalized in 15 November 27. Her chief complaint is chest pain. Present illness. 1 week before admission, patient had a several chest pain. It was about 2 to 3 episodes per day. Chest pain is described as mild, recurrent after meal. It lasted for only less than 5 seconds. No radiation, no associated symptoms, and will be relieved by rest with no treatment. The day before admission, at 14 o'clock, patient suffered a more severe chest pain after having a late lunch noodles. Chest pain was described as above but more severe. It lasted for over 20 minutes with shortness of breath, sweating, and no release by rest. She was transferred to Thailand Medical Center at 21 o'clock. At that, she was conscious. Her blood pressure is 160/70 mm over mercury, unnoted other vital signs. She was diagnosed myocardial infarction at 7 hours kg, prescribed with aspirin 81 mg, Plavix 75 mg, atorvastatin 10 mg, and Lovenox 0.4 mg. But the symptoms were not improved. Then she was immediately transferred to Cần Thơ Central General Hospital and hospitalized at 2:50 a.m. November 27. Admission status: patient is alert, well oriented, chest pain, no route, no abdominal pain, no edema, vital sign blood pressure is 140/80 mm over mercury, pulse is 86 beats per minute, temperature is 37 degrees Celsius, respiratory rate 22 times per minute. Past medical history: her active medical problem is number 1, hypertension, diagnosed at Kiên Giang General Hospital. Her blood pressure max is 280 mm over mercury. Blood pressure is 160 mm over mercury. Diabetics, diagnosed at Kiên Giang for 10 years. She had a stroke, brain hemorrhage at 27. Sequela with facial nerve injury and treated with acupuncture, physiotherapy, and traditional medicine hospital. Past surgery is unremarkable. Medication right now is using metformin pill 500 mg daily. Allergy is unremarkable. Family history unremarkable. Society history: no alcohol, no smoking. Partum antecedent 3003 and see menopause. Review system: 19 o'clock on the day that I did HB at home. General patient is alert, well oriented. The other symptoms remain normal. Physical examination: her vital sign, her pulse is 72 beats per minute. Blood pressure is 140/80 mm over mercury. Respiratory rate is 16 beats per time per minute. Temperature is 37 degrees Celsius. Saturation oxygen is 98% in blood. BMI 17.6. The other system is remain normal except cardiovascular examination. Her apical pulse pumped in the 6th left intercostal and located at the anterior axial line, and her extremity with normal range of motion with 2/5 strength in the left side body. This is because of the sequela brain hemorrhage. Problem of patient: so female patient 76 years old came to hospital because of chest pain. Here's some problem with patient through doing HMB. So we have number 1 problem is acute coronary syndrome. Number 2 is hypertension. Number 3 is diabetes type 2. Number 4 is brain hemorrhage, sequela with facial nerve injury. So acute coronary syndrome. So 1 week before admission, the chest pain characteristic is belong to stable angina. This is typical angina with 3 characteristics that happen below the sternum, happen with surgeon, and relieved by rest. But it is more severe over time. The stable angina become unstable angina, with risking to develop myocardial infarction because patients have 2 risk factors. It's the hypertension and diabetes. So in fact, we have 4 main risk factors of developing myocardial infarction. So number 1 is hypertension, number 2 is hyperlipidemia, number 3 is diabetic, and number 4 is smoking. Hypertension diagnosed 10 years ago without treatment, and the patient complained that she have to go to the hospital many times because of hypertension. Her maximum blood pressure is 280 millimeter over mercury, but she denied to have any medication. So based on CNC 6, patient is now in stage 2 group C. Diabetes, she treatment with metformin 500 milligram daily, but our recommendation is not enough to use only 1 drug to control her blood glucose. So we recommend to have another drug is limepiride 2 milligram. And number 3, brain hemorrhage with sepal. With facial nerve injury, she is now treatment with acupuncture, physiotherapy at a traditional hospital, but it have a very good outcome. So ACS syndrome. So ACS syndrome includes unstable angina, non-ST elevation myocardial infarction, and ST elevation myocardial infarction. So we use 2 laboratory tests to define which one of them. If you have evidence of ST elevation in ECG and troponin positive in dynamic change, we can define it's a ST elevated myocardial infarction. If you don't have any evidence of changing in ST elevation, only have 1 troponin positive in dynamic change, it's in non-ST elevation myocardial infarction. And if you have none of above, no evidence in ECG, no change in troponin, it's an unstable angina. We order some subclinical tests for patients. So number 1, your ECGs. Based on Washington, the ECG should be obtained when the patient first comes to your emergency room. Is only for 10 minutes. Within 10 minutes, you have to do the ECG. And then you have to do biomarker, CKMB, Doppler echocardiography, jet X-ray, CBC biochemical test, HDL, LDL, cholesterol, fasting glucose, and HbA1c because patients have diabetes. This is her ECG. So we can see we got sinus rhythm because we can see beat rate, and the heart rate is about 90 beats per minute. In this ECG, we see D1 is negative, D3 is positive. It's reminded that this ECG shows that patient have a right axial deviation with the angle is over 120 degrees. And we see left ventricular hypertrophy because S wave in V1 and R wave in V5 is greater than 35 millimeter. We see ST elevation in D1, ST elevation in AVL. We reciprocal ST depression in D3 and AVF. Is a lateral myocardial infarction. We see QS in V1, V2, and V3. It reminds the patient used to have a anterior myocardial infarction. We see the reflex image in V4, V5, and V6. So why do we have reflex image in here? It may interfere, it may remind us that patient have another area size of the heart have infection. So that's why I order another ECG with additional list is V7, V8, and V9. So this is the result of ECG. I want to remind you guys about the criteria of ECG. So the the criteria to diagnose patient with myocardial infarction in ECG is that no ST elevation greater than 1 millimeter in 2 continuous, and greater than 2 millimeter in D2, D3, AVF, or V2 to V6. And in V2 and V3, it has to be, ST elevation has to be greater than 2 millimeter in man and 1.5 millimeter in woman. Or the ECG show that there's evidence of no left renal block. Okay, this is the second ECG. This 5 hours later, during the time the patient entered to ER. This picture shows up the ECGs, the anatomy of coronary artery, and the relationship between the ECG and the anatomy. So in our patient, we have evidence of elevation in D1 and AVL. Is the location of MI is left lateral, and the affected coronary is left circumflex. But don't forget that we have QS in V1, V2, and V3. It's right here. The affected coronary artery is LAD, and we have the reflex image in V4, V5, V6. So we have to pay attention about it. We need to do the echocardiogram to see the. We expect to see the abnormal wall motion in the echocardiography. Chest X-ray, cardiac thoracic radial is greater than 0.5. It means that the patient has cardiomegaly. Vascular resection pattern, no evidence of pneumothorax. So why do we have to mention about pneumothorax in here? Because when patient comes to your emergency room with the onset symptom in chest pain, there's 5 diseases that you have to eliminate immediately. So number 1 in ACS, number 2 is pulmonary embolism, number 3 aortic dissection, so number 4 is pneumothorax, and number 5 temporal knot. Troponin T high sensitive, we do it 2 times. The first time the result is 0.237, and the second time is 0.435. The criteria to diagnose myocardial infarction with troponin is to increase more than 50% in 3 hours later. So we do the first time at 2 a.m. We have the second time at 6 p.m. It's more than 3 hours later, and the results show us that the result of troponin increased more than 50%. So it is positive. So we have the result of glucose levels in here. Fasting glucose for 10.5 millimole over liter. HbA1c 8.17 millimole over liter. This is the echocardiography of patient. We have abnormal lateral wall motion. It's in match with the ECG with ST elevation in D1 and AVL. As this is right here, this is our attention is here. Abnormal posterior wall motion. It shows there's something wrong with the posterior area of the side of the heart of patient. So when I read the echocardiography, I want to send patient to do the assay, but because of the financial problem, patient is incapable to do the assay. We have left ventricular hypertrophy, left atrial hypertrophy. You can see it also matched with the chest X-ray. So we believe this information. And we have mitral valve regurgitation 3/4, aortic valve regurgitation, bicuspid valve regurgitation 1/4. Ejection fraction is still good, it's 48%. PIPS is 42 millimeter over mercury. So that's why we have vascular resection in chest X-ray. So until now, we have enough information to diagnose, to have a final diagnosed patient with myocardial infarctions. Number 1, angina. This is the clinical sign symptom, the most important clinical signs and symptoms. We got ST elevation. We got dynamic change in cardiac biomarker. For patient prognosis, we have to use the TIMI score to evaluate the prognosis of patient. So patient is from the age to 65 to 74. We got 2 points. We got the weight patient is lower than 67 kilograms. We got time to treatment is patient have diabetes and hypertension is right here for 1 more point, and the time to treatment is greater than 4 hours, 1 point. In total, patient have 5 score. It means the patient have 12% mortality in 30 days. So final diagnosis: anterolateral myocardial infarction, 7 hours, key 1, TIMI score 5 points, and patient with hypertension and diabetes type 2. Treatment and plan. The goal of therapy is to reduce myocardial oxygen demand, improve coronary artery perfusion, prevent the thrombosis formation, and risk factor treatment. For the MI and hypertension, we use aspirin 81 mg, 1 tablet PO, PC mean after meal. We use Lovenox 0.4 mg. We got Plavix 75 mg, Crestor 10 mg, and Rabeprazole 20 mg. For hypertension, we got Cortisol 5 mg. Diabetes type 2, we use 2 drugs. It's glucophage and diamicron. So, plan and question. So, why we don't see nitrate in this patient? And why we don't see beta blocker in this patient? Do the patient need the assay that I answered before? Our target in this patient is to keep blood pressure below 125 over 80 millimeter over mercury because patient have diabetes with hypertension. And target to keep HbA1c below 7 and to keep blood glucose below 10 millimole over liter. Patient education is to let patient not have a recurrent myocardial infarction again, and to have a lifestyle change patient that like non-salty diet, or patient have to do more exercise. So this is the answer of my case.